Hi, I'm Paul Gerritson. I'm the co-director in North Carolina of the American Academy of Medical Ethics. Recently I had an opportunity to go to Duke University's Nasher Museum of Art and attend a fascinating and very informative panel discussion on physician-aided suicide. The panel discussion was moderated by Dr. Jeff Baker of Duke University, and the panelists were Dr. Farr Curlin of Duke University and Duke Divinity School and Dr. Timothy Quill of the Rochester School of Medicine. I want to just add a few comments to the videos that I recorded and posted on the website for you to look at. I'm in no way trying to add or detract from anything that was said there. These intellectual giants spoke very well for themselves. But as an audience member, there were a couple of things that I wished had been mentioned, and so I'd like to just add those to what was said. First off, let me congratulate the panelists and the moderator for the way the talk was conducted. Everybody involved is an intellectual giant, but they also clearly had a mutual respect for one another, even if they didn't necessarily agree on where they wanted the topic to end up. This mutual respect and honest intellectual debate became a form of respect for the audience as well, and I very much appreciated it. I've been to some of these events that devolve into ad hominem attacks and they become very vitriolic, and that's unfortunate because the educational aspect is lost. So congratulations to all three of you for putting on an excellent program. Now let me get down to the 3 points very quickly that I would like to add. Number one, a question was raised early on in Dr. Quill's talk when he asked the audience a question, something very much akin to, and you will see it. How many of you have experienced a bad death? About half the room raised their hand, and to be honest, so did I. But the question really piqued my interest because all of us die. We all will face death, right? So we're looking at a very subjective feeling about an objective fact. I think what Dr. Quill was really aiming at is how many of you have experienced someone dying that you didn't like what you saw? And again, about half the room was that way. Now, a question like that drives right straight into the emotional heart of the discussion. And anybody who wants to have an honest discussion on this topic has to recognize that emotions are almost foundational to why you would even have the conversation. That's what's driving the legislation. That's what's driving some of the passionate advocates for physician-aided dying. The emotional, subjective sense that what they've witnessed or what they anticipate for themselves is not good, it's bad. So we have to acknowledge and accept that emotions are a part of the conversation. We need to be empathetic towards the other person's feelings. We all want an empathetic practitioner on our side anyway. But we also need to recognize that going hand in hand with emotion and empathy have to be things like justice and law and autonomy. Autonomy is the second point I want to talk about. It comes up over and over again in this panel discussion and in any discussion that you have about physician-aided dying. What's key, autonomy is the sense that an individual has the innate right to determine what a healthcare practitioner will or will not do with and to their body. Everybody accepts that. It's become a very important tenet of healthcare and healthcare training. Patient autonomy, patient autonomy, patient autonomy. What's left out of the discussion is practitioner autonomy. Here's what I mean. It is a widely regarded and accepted medical fact that the patient-practitioner relationship, except in emergency situations, say for example, rolling up on a car accident, right, or somebody being shot in a ballroom, is otherwise entirely a voluntary, mutually beneficial relationship. and you're being, frankly, disingenuous or underinformed, if I might use that word, if you believe that the autonomy in the situation of a patient and a practitioner solely belongs to the patient. Practitioners have as much right in this voluntary relationship, or should have as much right in this voluntary relationship, to choose with whom they'll associate and how they will administer health care as the patient does in saying what they will accept and won't accept. Otherwise, it is not truly a voluntary, mutually beneficial relationship. So when you hear the word autonomy used in this talk, in those places where you hear it used strictly from the perspective of the patient, ask yourself, is the way it's being used giving the same due accord to the practitioner's autonomy as it ought? Finally, the thing I'd like to bring up is this issue of moral or ethical medical treatment being conflated with euthanasia. You'll see in one of the question and answer videos a very well-known and outspoken advocate for physician aid in dying here in North Carolina stand up and with great passion and emotion conflate this issue of, for example, extubating a patient or palliatively sedating or terminally sedating a patient with euthanizing the patient. And the questioner goes on to imply, if you're allowed to euthanize them, then why don't you voluntarily help them kill themselves? This is something that comes up all the time. Unfortunately, it goes to the heart of the difference between a practitioner and a lay person and their degree of training in medical ethics. So let me just try to clarify this a little bit. By definition, even Dr. Quill is quite clear on this. We are talking about patients who have a terminal disease. Within that scope of having a terminal disease, and we don't know for each individual patient whether it's terminal in the next 5 minutes or 6 months, but somewhere in that window, right? This patient has a pathology that left unimpeded, untreated, unaddressed, will kill the patient. There are times in medicine where a patient, in their own autonomy, will say, I no longer want a treatment you've begun, or I decline to accept you beginning a treatment on me. I don't want you to do that to me. I don't want to be intubated. I don't want that drug like a steroid. Or they may indicate, yes, we put me on the ventilator, but I no longer want to be on the ventilator. In doing so, the patient exercises their autonomous right to say, I no longer want somebody external to me to do this thing to me or to my body. And that is millennia old accepted medical practice, that when a patient says, don't do this to me, the practitioner either stops or doesn't start. Occasionally, the patient will have a surrogate speak for them if they can't, but they speak in that same role. And on even more, rare occasions, you may have a patient with no surrogate and who's unable to speak for themselves. And at that point, the practitioner then becomes a spokesperson using their best medical judgment for the patient. And they may recognize that what is being done for the patient is futile. It will no longer ameliorate symptoms. It will no longer stay the effect of the underlying pathology, and they will decide to cease doing that treatment. When they do that, their goal is not to kill the patient. It is to stop doing a futile treatment. Therefore, it is not an active act of killing, but it is simply stopping the impediment of the underlying pathology. That is very, very different than writing a prescription for an overdose of barbiturates or setting up an IV machine of some sort to administer IV drugs in order to hasten death, to actually supersede the pace of the underlying pathology and accelerate the person's death. Shorten the dying process, accelerate the point at which they are dead. They are two very different things and should not be conflated. One is widely recognized as morally and ethically acceptable, and the other is part of this grander discussion of the relationship of patient and healthcare practitioner at end of life. So with those three things said, let's be empathetic and understand that emotions are important, but let's also understand the need for justice and autonomy. Let's understand that autonomy is a two-way street, and let's understand there is a clear distinction between the morally and ethically acceptable terminating a treatment and hastening someone's death. Those things being said, I hope you find these videos very valuable. Overall, the talk was very enlightening and encouraging. Thank you.